The NP-STAT program began in 2009 as part of the Government of Ontario's Emergency Department Wait Time Strategy and the Aging at Home Strategy. The province's goal was to provide the right care in the right place at the right time, try to redirect people from the emergency department.
The province was operating on an idea that hadn't been tested, which was that if you used a nurse-led model, could you affect real change in patients' lives? And so for us, we had to not only prove them right, because we knew that we could do that, but we also had to prove it to the healthcare community who themselves weren't convinced. So our marketing role in the early days really consisted of helping senior management in long-term care homes understand who we were, but also the physicians who were tasked to provide care in long-term care to understand that we were a complementary role that could enhance the practice they were providing to their patients. And then we had to convince the patients themselves. So patients and families didn't know what nurse practitioners were, and so we had to go to each family council meeting, explain our role, help people understand that we were there to provide care. And as people started to see that their loved ones didn't need to end up in hospital, the program began to take on steam. The single worst place you can send a senior citizen in a long-term care home is to a hospital emergency room. And so our ability to go into the home and provide care where that person lives allows that person to achieve a safe and effective health outcome, but also to preserve their quality of life. But when you look at the way the Central East LHIN is structured, we have this large urban piece in Scarborough, and we have this entirely massive rural area where services are few and far between. So when we first began the rollout to homes, we had a lot of uptake in those rural communities because they weren't able to access their physician as quickly as you might be able to do in a larger urban center. If you're in a rural area, your physicians may not be available to the long-term care home as timely as a patient might need. So because NP-STAT NPs are able to go to the home, we can actually lay eyes on patients and figure out whether somebody's early enough in a disease that we can intervene quickly, or whether they're so far along that they need hospitalization. And because we're nurses, we can actually initiate some of the therapies that hospitals might initiate themselves. So we can do things like insert catheters, we can do things like wound care dressings, and we can sew up minor lacerations. Those sorts of skills that would otherwise have resulted in a transfer, we can deliver in the home. And the Ministry of Health and Long-Term Care came up from their health analytics branch with a new way of tracking long-term care residents who had arrived in an ED for potentially avoidable illnesses. And because they had that data, we could now see where our LHIN ranked against other LHINs in the province and which homes specifically had high transfer rates versus which ones didn't. So we've been using that data to not only guide the hospitals in terms of identifying who their partners are that they might need help, but also the homes themselves. So if we have a home that has frequent transfers, we'll use that information, bring it back to them for their own quality improvement plans to help them address why patients are being transferred and hopefully provide care where it's needed within the home. That's had real impact across the sector. And for us, that's huge, because what that means is the changes we've made as a program to ensure that an NP is aligned to each long-term care home in a cluster, and that an NP is aligned to each hospital, has had real impact on the number of transfers that arrive in that hospital. We've begun a new program around repatriation back from hospital to long-term care. So our value isn't just that we show up in the home, it's that we can show up in the hospital and track patients who have been transferred. And so what we've begun to do is to go to hospital discharge rounds, go link with other system resources like the GEM nurses through specialized geriatrics in our LHIN, and identify patients, get them out of hospital faster, and get them back home. Our LHIN and our province are focused on the philosophy of health links. And the philosophy of health links is based on taking complex patient needs and talking about what the patient wants while figuring out what every partner will do to support the patient in getting those needs met. We're doing that now and have been since this program began, because our challenge was we know long-term care patients are not like typical patients showing up in an emergency department. They are the most complex, they are the most frail, and for most of them, they're at the end of their lives. So the ability to bring someone to an environment where they're loved, supported, cared for, and to provide real clinical value to their journey in long-term care has had tremendous impacts for them and for their families. And when you're in long-term care, quality of life is what matters. So people aren't looking to live forever, but they're looking to live well. And if we can help support that, that's what the team's been able to do.